Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Bayer.
Hi, and thanks for joining this podcast on preventive cardiology and the cardiac risk continuum, where the theme has been Know Your Risk and Act Early. I'm Dr. Michael Baha from the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. And here in episode 3, we're going to talk about carotid ultrasound, seeing vascular age, where the theme is your arteries may be older than you are. So if you've missed episodes 1 and 2, you can go back and listen to those. In episode 1, we talked about primordial prevention and cardiovascular risk factors. And in episode 2, we talked about the coronary artery calcium score as a way of using an imaging test to define cardiovascular risk. And today, I'm so pleased to have my colleague and friend, Dr. Amar Jory, join us for this discussion. Dr. Jory is professor of medicine and cardiology at Queen's University and is the founding editor of the POCUS Journal, and he's, of course, an ultrasound and echocardiogram expert. So, Dr. Jory, thanks so much for joining us today.
Thank you, Michael. So great to be here.
In this podcast, we're talking a lot about preventive cardiology, knowing your risk, and we are believers in imaging and using imaging to define risk. And as I mentioned, the theme today is your arteries may be older than you are. Now, of course, there's more than one modality that we can use for imaging of the arteries. And today we're going to talk about carotid ultrasound and how that adds to risk assessment. So let's dive right in with that. So, Dr. Jory, you're obviously expert in carotid ultrasound. You've based a lot of your research career and clinical career around this modality and really have taken it to new levels. Let's just go back to basics. What is carotid ultrasound? What do you need to do it? And what does it tell us?
Great question. So I'll just go back to your opening statement where you mentioned your arteries may be older than you are. So, what does that actually mean? What we're talking about here is this concept of vascular age, which often resonates with patients. And it's a way of us to communicate that the biologic burden of atherosclerosis might be greater than that person's chronologic age. So it helps us understand whether we need to pay more attention to their atherosclerotic risk or not. And as you mentioned, carotid ultrasound is a tool that lets us see atherosclerosis. Specifically, it lets us see subclinical atherosclerosis, which means plaque buildup that has not yet manifest in symptoms and perhaps outcomes. And what I like about it is that you can directly see disease, you can see plaque. So it really shifts the conversation from probability of disease to presence of
Mhm.
disease.
That's so true. And carotid ultrasound is relatively easy to do. It doesn't come with any radiation for the patient. But tell us about actually how to do it.
That's a great question. I think of it in many ways analogous to calcium scoring. It's a way to visualize atherosclerosis. And the way we do this is we put a probe on the patient's neck and focus on the carotid artery, and we're looking for plaque buildup. We can often see the layers of the carotid artery, including the intima and the medial layers. And atherosclerosis is an intimal process. So, what we would see is buildup of that intimal layer. There may be protuberant plaque or there may be layered plaque. It's analogous to using calcium scoring, but it is different. So, calcium scoring is conducted by CT scanning, and that's the gold standard for coronary plaque calcification. It's a very good test, strong prognostic data, and it's an excellent rule out tool. What the difference with carotid ultrasound is that it's able to detect earlier stage atherosclerosis, so before calcification. So it gives us an idea of the systemic vascular disease state within a patient and not just the coronary bed, and helps us identify the plaque burden and distribution. And as you mentioned, there's no radiation. So you can repeat it every few months or a couple of years to determine whether risk has changed. And what I'm very excited about is the fact that it can also be done at the bedside.
Yeah, that's super exciting. But I want to go back to the assessment of the results. To talk a little bit about how one of these studies should be interpreted and maybe even comment on plaque type that could be seen by ultrasound.
Yeah, that's a great question from the perspective of a preventative cardiologist. So, not only focusing on whether velocities are increased or not, but is there overt evidence of atherosclerotic plaque present? That is telling me that disease is there and has begun, and it is indicating that this disease could become more extensive in the future. And this type of patient may not be only at risk of stroke, but may also be at risk of cardiovascular coronary events. This is because this part of the vascular system, the carotid artery, is part of the same vascular system as the coronary arteries. So it's kind of like a barometer of disease elsewhere. It's an imaging biomarker that can inform risk for patients. Atherosclerosis is part of a continuum, and we need to think of it in that sense. So, what carotid ultrasound does is it picks up disease earlier on before it's on that point of the continuum that there are events like heart attacks and strokes. Now, going back to your question, how does that relate to being able to do it at the bedside? We're just interested in whether plaque is present or not. You can use semi quantitative parameters such as the plaque score, or you could use even more advanced parameters such as plaque area, plaque height, or plaque volume. But the point here is that simply visualizing the presence of plaque is giving you information. And that's why that information at the bedside can be important with respect to risk stratification and determining whether subclinical atherosclerosis is present or not. We've shown that using point of care ultrasound is very good at picking up carotid atherosclerotic plaque. Now we're trying to move that into office-based assessment to see whether that could change the way a patient is perceived in terms of their risk at the bedside in the context of primary prevention.
Right. So it's part of like almost part of the physical exam at that point.
Exactly. So, for example, if you had listened to a carotid bruit, you would be thinking, there's some atherosclerosis there within the carotid. This is the next level of directly visualizing the atherosclerosis that's there and realizing that this is part of their subclinical risk continuum.
That brings me to two or almost three important points. First of all, I think suffice to say, the more plaque you have, the more segments of the carotid artery you have with plaque, the higher the risk. Plaque and plaque burden is one of the best predictors of events in primary prevention. But I think our listeners will be very interested in this idea of using it at the bedside. So, how easy is it to do, and how long would it take me to be proficient at least making that binary assessment of plaque or no plaque?
Yeah. Well, as you know, point of care ultrasound is exploding, and especially some of the newer people that are coming out of training, they have already developed skills to look at the carotid artery. But what we're trying to explain to them is use those same skills. Let's focus on the carotid artery. And now, what does plaque look like? And how can we quantify plaque at the bedside? We're very good at using advanced methods of plaque quantification. But what we found is that you may not need to do that when you're screening for atherosclerosis. What we found is that the carotid plaque score, which is a very basic, simple way to sort of take a more binary approach to the presence of plaque, is predictive of cardiovascular outcome. And we've done large outcome based studies to show a plaque score greater than 2 uh, is a really good score to differentiate patients that are going to have outcomes versus those that aren't. And so, what is a plaque score of 2 that can be done at the bedside? Well, it's a very simple count of whether you see plaque in particular segments of the carotid artery. So, what we do is we divide the carotid artery on the right and left into three segments: the ICA, the bulb, and the common carotid artery. And if you see plaque in one of those segments, you give them a score of 1. So, your total score for both the right and left can be 6. And so, a plaque score of 2 or greater is considered higher risk. We're talking about general screening, improving our approach to cardiovascular screening, especially in primary prevention and in patients that are currently asymptomatic. So, why not bring additional information that is quick, easy to do, safe, and inexpensive?
So that's great. And I want to ask you this. I know there's been research that shows that showing patients their carotid plaque can be motivating for patients, right? It brings the message home. Tell me about that data.
Yes. So this is my area of recent passion. I love this area, and I'm so glad you brought it up because it brings in this interdisciplinary approach where I'm working with behavioral scientists as well as people that are interested in improving risk stratification. And we're coming together the psychology and the biology of atherosclerosis and how we can improve outcomes in patients. And you show a patient that they have disease, that's going to change their perception of their disease. You tell a patient that their risk score is 15%, that doesn't really resonate with them. They're not exactly sure what that risk score means. You can sort of explain that it's a population based statistic. And so their risk is higher because other people, but when you actually show them a carotid ultrasound and say, look, there's a plaque here. I've had patients that say, oh my gosh, I really need to stop smoking. So it really delves into this concept of risk. So it's the understanding of what their risk is from not a statistical perspective, but a visualized and intuitive perspective. And it changes two things. It changes the patient's perception of their risk because now they're seeing their plaque, but it also changes the prescriber's perception and their um, intent to navigate them through the gray areas of our guidelines and helps them determine the personalized risk of their patient. So, this work has been shown by multiple investigators, and it works not only for carotid ultrasound, but also if you show people their calcium score, the CT, and show them the calcification, showing them their disease makes a change. So when we use imaging, when the answer isn't obvious, that's when we move from uncertainty to more clarity. And it makes a change with respect to prescribing behavior and adherence.
So great points. So a couple rapid fire questions. Give me your ideal patient for a carotid ultrasound.
Great question. So, this is the intermediate risk patient where there is uncertainty. For your high risk patient, you know what to do. For your low risk patient, you know what to do. It's for your uncertain patient where you're trying to decide whether they need to be on a statin or more aggressive lifestyle changes would be beneficial. That would be the Framingham risk score of sort of 10 to 19, or the prevent score between 5 to 10. So it's that intermediate risk group where there isn't a clear indication for the statin either. And what I like to call the gray area, where there's shared decision making occurring and bringing in the visualization of the carotid ultrasound and the presence of plaque clarifies what we should do moving forward.
That's a great intermediate risk patient. What would make that patient perfect for a carotid ultrasound instead of a calcium score?
A lot of that has to do with what you have available and your patient. If you feel that if something's going to change after the test is done, then that's the test you need to do. So if you discuss with your patient that we could get a calcium score, and if it's above a certain threshold, then I'm going to be worried about you, and that's going to be high risk. Would you be interested in moving towards more aggressive therapy like statin? And if you feel like your patient would move towards that, then calcium scoring kind of makes sense. If you're thinking that the number is not going to resonate with your patient, or you may have problems with accessing calcium scoring, then you may think of that carotid ultrasound might be more useful. Carotid ultrasound also has the advantage that it could be done again in a couple of years from now. And it also may pick up non calcified atherosclerosis. So that might be better for younger patients. It depends on the context and the patient and whether something will change once you do that test.
Such a good summary. And certainly, both tests are telling us about the health of the arteries beyond what risk factors can tell us. They're telling us about the arteries might be older than we think they are. So, Amr, let's say we have a patient and we have detected carotid plaque. We're going to want to involve all the members of our preventive cardiology interprofessional care team in the discussion of risk with this patient. What does that look like in your practice?
Great question. So I think the important point here is that this is not only a physician only approach. And so your team can include primary care physicians that will be managing the patient on an ongoing basis, and them understanding if you've done a carotid ultrasound in your office, how they need to manage that patient moving forward. Now, it also may involve sonographers or POCUS trained clinicians. We might be sending the patients to a vascular lab to get plaque assessed. And so we need to explain to the sonographers what they're looking for. It may also involve pharmacists helping with respect to adherence optimization. Often asymptomatic pharmacists can play a role in explaining to patients that preventative therapies are necessary, even though patients are not having symptoms. And then finally, nurses are also very important because they are often the ones that are helping with behavioral change on an ongoing basis and with continuity of care in outpatient clinic visits as well as in hospital. And also, if patients end up being referred to any type of lifestyle modification programs. In my practice, I like to see this as a interprofessional team. And the key here is that although imaging and the carotid ultrasound was the trigger, it's this entire interprofessional team that helps deliver the prevention.
And it's all about knowing your risk and acting early. So, this was a great discussion of the carotid ultrasound. Dr. Jory, I want to thank you for joining this podcast about preventive cardiology and teaching all of us about the carotid ultrasound for which you are expert. I hope our listeners appreciated this discussion of an important topic in preventive cardiology. Thank you.
Thank you.